Okay, so when we were in the upper limb stuff and we were looking at the hands, we had the x-ray of the hand itself, and we had to be able to make sure we could differentiate between left and right hands. But remember that the x-ray is almost always supposed to be like this, where you're looking at the palmar surface, right? So your thumb is going to be the indicator of telling you which hand you're looking at, right? And the thumb has this weird curvature to it that really helps you understand that if your thumb is curving like this, then it must be your left hand, right? And if your hand for any reason on any x-ray is flipped the other way around so that you're looking at the dorsal surface, they kind of have to tell you because that's not standard. If they don't, then again, now you can see that there's a big difference between curvature, right, depending on how the hand is placed. Not just that, there's also the radius and the ulna, right? So you should use that information to be able to understand that. But mainly we saw in the hand video that the capitate was the landmark to really help you identify where the other marks, the other tiny carpal bones are, because the capitate is this really big cylindrical bone. When we get to the knee, we have a similar thing going on, because now we have to identify what we're looking at based off of the fibula and the tibia. The tibia is the really big bone. The fibula is a really skinny one. And depending on which side you see the fibula, you can identify that as the medial side. Right? So in the knee, right, the anterior cruciate ligament and the posterior cruciate ligament are really big deals, and they're often injured. The lateral femoral condyle to the anterior tibia, right, so the lateral condyle to the anterior tibia is the anterior cruciate ligament. So the name of the ligament is based off of where on the tibia it connects, right? The posterior cruciate ligament goes from the medial femoral condyle to the posterior tibia. So you can see that's your posterior cruciate ligament right there. Right, and in this image right here, this is basically a coronal MRI of the posterior aspect of the knee. Right, so you're looking at the knee from behind, and the asterisk right here marks the posterior cruciate ligament. Okay, so you can see you have your medial femoral condyle, your lateral femoral condyle. Right, so this is the lateral part right here of your right leg, and you're looking at it from behind. This is the head of the fibula. You can see your lateral tibial condyle and medial tibial condyle, and you see this thing moving here, right? So this guy moving here is pretty much giving you the sign that you're looking at your posterior cruciate ligament, because it's coming to the back, and we're looking at the knee from the back. Almost always you're going to have a pretty good, clear image to be able to identify which ligament it is, but oftentimes you have to use more information to figure out which ligament it is, and that's what these tests are about. So you have your anterior drawer sign, the posterior drawer sign. Then you have some tests that work with your abduction and adduction of legs, and then a big guy, McMurray test. These things are going to be a big deal when you get to step 2 CS as well. You have to be able to perform these. So the anterior drawer sign, and they're named very well too, so you'll always know what's happening. So the anterior drawer sign checks the anterior cruciate ligament, which is very nice. Bending knee at 90-degree angle, there's going to be increased anterior gliding of the tibia relative to the femur because of an ACL injury. The Lachman test also tests the ACL, but is more sensitive, right? So that's the one you really want to think of. And there's going to be increased anterior gliding of the tibia when the knee is bent at a 30-degree angle, right? So the 30-degree angle one is the more sensitive test than the 90-degree angle one, and you should make sure you remember that. Anterior cruciate ligament injury is very, very common. The posterior drawer sign is when you have the same position, bending knee at 90 degrees, but there's an increased posterior gliding, all right, due to PCL tear. Okay, so the what do you call it? The tibia is moving to the back a lot more than it normally would. Now, in a normal person who doesn't have tearing of either the ACL or PCL, it doesn't really move that much at all, actually. So you could hold the lower leg like that and just push into it or pull it, and it should not move too much, right? There shouldn't be some crazy amount of gliding. So that checks those guys. I wrote over here, ACL or PCL tear. Which one would you rather have? PCL is already rather floppy as it is. Plus, rarely does it get taut in normal motion. The anterior cruciate ligament is maintaining normal knee motion and tibial articulation with the femur. So PCL tear is more manageable. All right. So the ACL is very frequently injured, and in normal walking, this actually gets pulled quite a bit. All right. So if you're a runner or if you do any kind of crazy sprinting, right, you can totally cause damage to your ACL. And you feel the pain in your normal motion. Like you'll be walking and you'll feel pain because it's kind of pulling in a weird way. The other things here, your abnormal passive adduction, adduction, and McMurray test. Abduction is always away from the body. So this is where you kind of move your leg out of the, laterally basically, not medially. Right? So knee either extended or at 30-degree angle. Lateral force causes medial space widening of the tibia, and this is the valgus force. Right? So lateral, L, valgus, it's really easy to remember. So this is your valgus force. So you're gonna put force from the medial side laterally, and you're gonna notice that because of this medial collateral ligament tear, your leg is moving laterally a lot more than it normally would. The opposite of that is also another thing. So abnormal passive adduction. Adduction is when you add things together. So when you bring your legs together medially, with the knee extended or at 30-degree angle, the medial force or a varus force causes more lateral space widening of the tibia because of LCL injury. Right? So there should be a limit of how much this motion occurs. If it's happening more than normal, then that's a sign of a tear of those ligaments. Lastly, you have this McMurray test, which they love making you do on Step 2 CS. Basically, during flexion and extension of the knee with rotation of tibia, you will either hear pain or popping on internal rotation, as you can see here, internal rotation, or pain or popping on external rotation. Right? And you're going to hear that over here at the knee. So if it's a lateral meniscus tear, internal rotation causes the pain or popping. If it's a medial meniscus tear, then external rotation causes the pain or popping. Right? So that's what the Lyme is about. Lateral, internal rotation, medial meniscus, external rotation. Right? And your menisci are right here. This thing right here. So medial meniscus, lateral meniscus. If it tears a little bit, then rotating the foot, right, in either direction causes pain. Down here is a question about the PCL. Because remember we just said that the PCL is rarely ever actually that much damaged, but then UWorld actually asked a question about it. So this is saying a 20-year-old man comes to the hospital with right knee pain after an injury during a soccer game. When asked how the injury occurred, he states, "I fell to the ground after colliding with my teammate, and then an opponent fell on my shin. On physical exam, his knee appears slightly swollen, and there is excessive posterior displacement of the tibia when pressure is applied to his anterior tibia with the knee in the flexed position. What structure is most likely injured?" So they're literally showing you the posterior drawer sign, and they're telling you it's a positive posterior drawer sign, so he has PCL damage, right? That's it. So you gotta know your signs, you gotta know these tests really well, and based off of those tests, you're gonna be able to pick out what is the actual injury. The next page goes on to a similar table that we saw in upper extremity. Now we're looking at lower extremity nerves, right? So the main nerves and what muscles they go to, as well as their sensory function, are what I've summarized up here. Right? This is the general summary of everything. So femoral nerve goes to your anterior thigh, right? And you have sensory of the medial thigh, knee and leg. Your obturator nerve goes to the medial thigh, and it has some sensory innervation of your medial upper thigh. The sciatic nerve goes to the posterior thigh, it doesn't have any sensory stuff. Your deep peroneal nerve goes to the anterior leg, as well as your big toe and your other four toes. Okay, so extension wise, superficial peroneal nerve, right, this one goes to your lateral leg, and it has sensory innervation of the lateral leg and the dorsum. And you really need to be able to talk about these things. So you need to keep studying this until you can describe these things without having the book in front of you. That's the main theory here, main concept here that we're all trying to achieve. Okay. So the book starts off with iliohypogastric nerve, right? So iliohypogastric nerve, what is this for? So this is a hypogastric nerve, so it's like right there going upwards. It's at the waist and going upwards, and it's usually injured in an abdominal surgery, right? It provides sensory innervation to the suprapubic region and motor innervation of the transversus abdominis and internal oblique muscles. Very rarely is any of this really tested, but abdominal surgery is a pretty common thing. And if you have injury to the iliohypogastric nerve, you get burning or tingling pain in surgical incision site radiating to the inguinal and suprapubic region. Never really seen a question on this, but if you get a question, I always say that if you get a question on something you don't know about, make sure you can cancel out all the other answer choices you do know about. So this should stay in the back of your mind just so you have some knowledge of it. The next one is a genitofemoral nerve, right? This is going to give you the sensory innervation of your scrotum, labia majora, and the medial thigh. And it also causes the cremaster reflex, right? So this is more significant than iliohypogastric. If you have laparoscopic surgery, especially in a female, this can cause injury to the genitofemoral nerve, leading to a decreased upper medial thigh and anterior thigh sensation, right? We just said that your femoral nerve was sensory innervation of the medial thigh, right? And upper medial thigh, obturator nerve, right? And those two guys, the operator and femoral nerve, they do later on have connections to the genitofemoral nerve. They're branching off of it. So decreased sensation of upper medial thigh and anterior thigh beneath the inguinal ligament, which is the lateral part of the femoral triangle. And you lose your chemisteric reflex if it's a male. Alright? So that's genitofemoral. Lateral femoral cutaneous nerve is one that provides sensory innervation to the anterior and lateral thigh. It's going to get injured in tight clothing or obesity, pregnancy, any pelvic procedure, and you just end up losing thigh sensation in the anterior and lateral section. And so right now we're really starting to notice that what part of your thigh is missing sensation kind of determines what nerve it is. And lower extremity nerves are a tad bit harder than upper extremity nerves because we're all so well accustomed to looking at upper extremity nerves. We've seen it a lot of times. We know the brachial plexus. We've visited it many times. You want to make sure you visit these nerves a lot of times too, and make sure you see it as often as possible. And I'm going to show you a lot of pictures coming from Netters and teachmeanatomy.com to really get a good handle at the sensory and motor innervation there. So don't worry too much right now. As soon as we're done looking at this, we'll go into that. So this was your thigh sensation and anterior lateral, right? So lateral femoral cutaneous. Your obturator nerve, femoral nerve, sciatic, and common peroneal, as well as tibial. These are the real guys you have to worry about. Those are the big guys. That's a femoral nerve. Obturator nerve. Obturator nerve is sensory innervation of your medial thigh, right? Just the medial part of the thigh. And this nerve gets injured in pelvic surgery, which is also pretty common. And the only thing that you lose when your obturator nerve is gone is medial stuff. So you lose medial thigh sensation and you can't move your legs medially. Very common scene in many step 1 questions. I've seen it a lot on UWorld too. So if you get a patient who can't adduct their legs and they don't have much sensation on the medial area, that is an obturator nerve injury. Right? It provides motor innervation to a bunch of muscles, and that's why you have this loss of adduction. The femoral nerve is for the anterior thigh, as well as the medial leg. Right? And UWorld had a bunch of pictures for this breakdown. I'm going to show you some of them later on. So anterior thigh and medial leg. Again, this is also injured in pelvic stuff, but now we're seeing pelvic fracture. Right? And what happens when you have femoral injury? This is very similar to or analogous to radial nerve. You lose leg extension. Right? There's also a decreased patellar reflex. Your patella is also on the extensive surface. Over here I mentioned a femoral nerve block because this is actually mentioned a lot of times in various NBME, as well as I believe in one URL question. So the optimal site for femoral nerve block is in the inguinal crease at the lateral border of the femoral artery. This anesthetizes the skin and muscles of the anterior thigh, femur, and knee, as well as the saphenous nerve. Can have mononeuropathy due to pelvic fracture or compression by a hematoma. Right? Any of those things can lead to femoral nerve issues where you are now unable to extend your leg. The sciatic nerve only has motor innervation, no sensory, and it goes to these muscles, right? So biceps femoris, adductor magnus, etc. And this nerve, you've heard of sciatica, right? So it's usually related to herniated disc, and it splits into the common peroneal and tibial nerves later on. So if you have issues with the sciatic nerve, you're going to have issues with common peroneal and tibial nerve in terms of what innervation it goes to. But sciatic nerve itself only directly goes to muscle. After branching into common peroneal and tibial nerves, it also has some sensory parts to it. So let's take a look at that. Right, so here we can see your common peroneal nerve. Right, in this image, it's going around the fibula, and you see how there's like compression right here of the common peroneal nerve. So it's got a superficial peroneal nerve and a deep peroneal nerve. The superficial peroneal nerve gives sensory innervation to the dorsum of the foot, except the web space between the hallux and the second digit. Right, so right there, you see? That's deep peroneal. Superficial peroneal is everything yellow here, except between the first two toes, the big toe and the second toe. Right, that space is your deep peroneal nerve. This one gives sensory innervation to the web space between the hallux and the second digit. And the hallux is basically a really big toe. Motor innervation from the superficial peroneal nerve is the peroneal longus and brevis, and it's basically for dorsiflexion because it's on the dorsum. Deep peroneal nerve has motor innervation of the tibialis anterior, right? And that's going to be, we're going to see actually right here, right? PED, right? This is a great way of memorizing the ped and tip. You think of this as like a pediatrics tip. So ped, tip, peroneal, everts, and dorsiflexes, right? That's basically everything these guys are doing together. The peroneus longus and tibialis anterior, peroneal, everts, and dorsiflexes. And this is an image showing you eversion is basically lateral, and dorsiflexion is towards your face, upwards, right? If there's injury to the common peroneal nerve, and usually it's right here. Often, I think I saw a question it was a cast that someone was given around their leg and they squeezed their leg too much, kind of caused injury to the common peroneal nerve. If you have injury to the common peroneal nerve, you get loss of sensation on the dorsal foot, so this entire yellow region down here, as well as foot drop, because you won't be able to do the ped. You won't be able to evert and dorsiflex, right? So foot drop, you're going to be inverted and plantar flexed. Right, so inverted like this and plantar flexed as if you're going tiptoes. Loss of eversion and dorsiflexion, and you get something called the steppish gait. Okay, so tibial nerve is your other guy that's really significant. It is another branch of the sciatic nerve. Your tibial nerve has sensory innervation at the sole of the foot. Right, so here I'm showing you the sole of the foot. You can see it's lateral plantar, which is a branch of the tibial nerve. Medial plantar, another branch of the tibial nerve. A little bit of saphenous nerve right here, which comes from the femoral nerve. This sural nerve right here, which comes from the common fibular. And medial calcaneal, which comes from, again, the tibial nerve. Right? So tibial nerve is taking care of your basic entire sole of the foot, except this red and purple area in the corner. Its motor innervation are to the biceps femoris, long head, triceps surae, plantaris, a bunch of flexor muscles of the foot. Right, that's really all there is to it. So the flexor muscles of the foot now. So it's the opposite of common peroneal. So here it's tip, right? Tibial, inverts, and plantar flexes. And if it's injured, you will no longer be able to invert and plantar flex. You can't stand on tiptoes. Inability to curl toes and loss of sensation on the sole. In proximal lesions, foot is everted at rest with loss of inversion and plantar flexion. Alright, so you can't do it. So ped tip really tells you what the normal activity is, and then obviously if you have injury, you can't do those normal activities. Right, normal action of those nerves. Tarsal tunnel syndrome is something that was tested in NBME. Tarsal tunnel syndrome, basically you can see your posterior tibial nerve going through the tarsal area past the flexor retinaculum. In tarsal tunnel syndrome, you have compression of the posterior tibial nerve in the tarsal tunnel. This is analogous to your carpal tunnel. So if you have this compression of your tibial nerve, you end up having pain and paresthesias on the entire sole of your foot. Right? Pain and paresthesia in the medial aspect of the ankle, heel, and foot. Right? And then it goes down here, you feel the pain all the way. Right? So that's something that is pretty rare. I don't know who it would directly happen to very commonly. But if it shows up on your test, then it shows up on your test, and you should know what that's about. Right? So your tibial nerve goes through the tarsal tunnel like that. The other guy that's very high yield, UWorld had like 3 questions on this thing, your superior gluteal nerve, right? And then your inferior gluteal nerve. The superior gluteal nerve gives innervation to your gluteus medius and gluteus minimus, as well as the tensor fascia lata. It can be injured iatrogenically during intramuscular injection to the superomedial gluteal region, which is pretty much the wrong region to give it to. Prevent by choosing the superolateral quadrant, preferably the anterolateral region. And this is the anterolateral region being shown right here. It's known as the von Hochstetter triangle. Right, so you give it on the lateral side, not the back, not on the actual buttock area, but laterally. And if you have injury to it, though, if you do cause injury, then you start noticing something called the Trendelenburg sign, where the pelvis tilts because the weight-bearing leg cannot maintain alignment of the pelvis through hip abduction. Right? So when you stand, if you injure the right one, when you stand on your right leg, your left one drops, and it's because it can't pull. This right muscle is unable to pull and keep it straight. Lesion is contralateral to the side of the hip that drops, ipsilateral to the extremity on which the patient stands. Right? Each of these guys, the gluteus medius and minimus, what their job is to pull the opposite side up and keep you leveled. And this is a question regarding that. So this one says, a 63-year-old man comes to the physician's office due to long-standing osteoarthritis that is refractory to over-the-counter analgesics. After discussing various treatment options, the patient is referred to a surgeon for right total hip arthroplasty. His acute post-operative course is unremarkable. During a follow-up appointment, the patient reports difficulty walking despite minimal pain. On exam, he leans to his right side when walking. When asked to stand on his right leg, the patient's left hip tilts down. What nerve is most likely injured? And obviously superior gluteal. To make this question harder, they can put either right or left superior gluteal. And you have to understand that if he's standing on his right leg, and that's when the issue is showing up, then it says right superior gluteal. The patient has right superior gluteal nerve damage due to his surgery, and his condition is just like the image here for Trendelenburg sign. When he stands on his right leg, his left hip falls. Weakness of the right gluteus medius and minimus is causing him to lean to the right, so that's the gluteus medius lurch, and his left hip drops when he stands on his right leg. Okay, and this can be on the other side as well, and just gotta make sure you keep it all straight. The inferior gluteal nerve goes to the bigger muscle, which is your gluteus maximus, and that usually gets injured in the posterior hip dislocation, at which point you'll have difficulty climbing stairs, raising from seated positions, or doing any loss of hip extension, right? Extending your hip. And these are basically major workouts, right? So you can't do the Stairmaster anymore, you can't really do squats anymore, etc., etc. The gluteus maximus is a really powerful muscle, and notably one of the biggest muscles you have. So if you have a posterior hip dislocation, you mess up the inferior gluteal nerve. So that kind of sucks. Lastly, we have our pudendal nerve, and this thing goes to your perineum, right? And we saw the pudendal nerve earlier in GIT when we were looking at the dentate line and above and below the dentate line. So where does this get injured? Usually it'll get injured because of stretch injury during childbirth. Right, so you have sensory loss of the perineum, and motor innervation of your external urethral and anal sphincters will not be good anymore. So you end up getting decreased sensation in the perineum and genital area, can cause fecal or urinary incontinence, can be blocked with local anesthetic during childbirth using the ischiospine as a landmark for injection. Right, so you can see your pudendal nerve is right by the ischiospine. And this is how you do a pudendal nerve block. Let me see. If we go back to yeah, it's in the pathology, right? Actually, one of the last few things in pathology. Or is it? Damn. Dentate. No. Was it pectinate then? Okay, right here. So this thing is also called the dentate line, but I don't know why I couldn't find it. Either way, you can see here that below, down here, is the pudendal nerve, right? Somatic innervation. External hemorrhoids are going to be painful because external innervation is by pudendal nerve, and that's somatic. Right, so I just wanted to come back and show you that. Alright, so that's done, and that's pretty much all the main nerves of your lower extremity. You definitely want to make sure you look at this a couple times as well. Make a table if you have to where you summarize it all into one page, because this is taking up more pages. And have good visual memory of what's being shown here. Right? All the color-coded visualization, as well as how the nerves are coursing. The PED tip is really nice. There's only like 2 of these 2 up here that you need to memorize separately. Otherwise, from obturator downwards, everything needs to be memorized very well. And the pudendal nerve. And this image from Amboss does a really good job showing you the entire innervation. Right, so all the nerves we just saw. So you saw your iliohypogastric nerve, that's right up here. And they tell you that it's in the suprapubic region, right? So that's what that is. That's your suprapubic region. Your pudendal nerve itself is the penis innervation. Genital femoral nerve is around the genital area. That's that green, right? Lateral cutaneous nerve of the thigh is right here. Femoral nerve is your anterior thigh, and then it's going to go to your lateral leg as well. Right, so femoral nerve is the green and the gray. Right, so anterior thigh, lateral leg, femoral nerve. Obturator nerve is this medial thigh area, but the upper medial thigh was the femoral nerve. Okay. Let's just make sure of that, right? So upper medial thigh, genital femoral nerve, right? So that's the femoral branch right there, and the genital branch right here. Okay. Common fibular nerve is this entire area. Remember that the common peroneal nerve or common fibular nerve is kind of branching around the fibula right here, and it can get injured because it's very superficial. So it kind of innervates all of this. Then it goes down into your leg, into your foot, and in the foot, the superficial peroneal nerve was all this red area except the yellow area of between the first two toes. That area was your deep fibular nerve, and the sciatic nerve has this corner. As well as the sole of your foot, right? The whole sole over here, this green, pink, and blue is all tibial nerve, right? Different branches of it. So that's the sensory innervation. Let's take a look at these two questions. These are both UWorld questions. This over here is just a vocabulary list of what the muscles do, and you should know them, but you shouldn't know them as a list and memorization. You should know them because you know where the muscles are. Like when you look at your legs and you touch muscles, you should know what each muscle is. So the first one says 28-year-old primigravida is seen in the postpartum clinic a week after spontaneous vaginal delivery under epidural analgesia that was complicated by prolonged second stage labor. The patient has had frequent fecal incontinence since delivery as well as mild perineal pain relieved by ibuprofen. There are no other medical problems and the pregnancy was uncomplicated. On exam, a healing perineal laceration is present and shows no signs of infection. Rectal exam reveals decreased anal sphincter tone and loss of the anal wink reflex. What is the most likely cause of her fecal incontinence? And that had to be pudendal nerve injury. Right, she's pregnant. We just talked about it. We just talked about the pudendal nerve block you can do. And oftentimes during delivery, in case you didn't know, oftentimes during delivery, women do end up passing feces. Right? It just happens because the anal sphincter is closed up and they're in so much pain, and there's just no way for them to hold it back in. So oftentimes that does occur. And what's recommended during, when you obviously know delivery is about to be coming, so you try to get the mother to just, poop as much as she can before the day and moment of delivery. So it's a very common thing to occur, and this is a very plausible question that you can get. Next one is a 43-year-old man comes to the physician due to difficulty walking. He was seen at an outpatient clinic 2 days ago and received a deep intramuscular injection. He had no trouble walking at the time of the appointment, but started having problems later that day. He denies any history of trauma or pain at the injection site. Physical exam is negative for local erythema and swelling. When asked to walk across the room, his right hip drops every time he raises his right foot off the ground. Okay? At what location did he most likely receive his injection? So this is a really interesting question because now they're not talking about standing on a foot, but rather raising the foot. And they tell you, right, that when asked to walk, every time he raises his right leg, right, his right hip drops every time he raises his right leg. Right, so where did the injury occur? Well, it's going to be in the supromedial quadrant of the left buttock, right? Because the hip that's dropping is opposite of the hip that's not pulling it up. So if his right hip is dropping, it must be that he's standing on his left leg, right? If he's standing on his left leg, then that's the one that's injured. So supromedial quadrant of the left buttock is probably where he got his injection, and that's bad. He is exhibiting the classic Trendelenburg gait. This gait is observed when there is injury to the contralateral superior gluteal nerve. The superolateral part of the buttock is a relatively safe site for intragluteal injections, although the anterolateral gluteal region is preferred, as shown by the von Hostetter triangle above. Because I put it on the other page now. Okay. Stop. All right, there you go. Ooh, okay. I'm gonna move this up, and now it should be in front of the image. Okay, perfect. All right, so there's that. And then from here on, I'm basically just sharing the netter's anatomy stuff now, so you can see your anterior compartment of thigh muscles are all generally supplied by femoral nerve, and your anterior thigh sensory supply is also femoral nerve, right? And then here I'm showing you the pictures of all the muscles, where they are, right? So some of these are muscles you can't actually touch, but you can work them out, right? So they're like on the interior surface of stuff, like your psoas major, your iliacus, right? These are really critical muscles that really help you jump, run, all of that. Your purple one here is the sartorius. That's definitely one you can touch. You can touch these yellow ones, the rectus femoris, the blue one, vastus lateralis, right? Vastus medialis. These are all muscles that are part of your anterior compartment. And the rectus and vastus muscles, these are the ones that make your quadriceps, your quads. So every time you're working on your quads, just remember you're using femoral innervation, right? And all of these muscles, they're all here to help you extend, right? Your quadricep muscles are for extension at the knee. You're pulling your knee up. Let me see. And then these are showing you a couple more that I missed. The others that are not shown there is right here. The quadratus, iliacus, psoas major, psoas minor, right? This is a netter's anatomy image of it. And then this is a picture that was related to something in UWorld. So really interesting question. I really don't think I don't even know if it's still part of UWorld, but they asked it, so here it is. 26-year-old man comes to the emergency department with fever, right flank pain, and difficulty walking for the past 3 days. 1 week ago, he was treated with cephalexin for furunculosis. He was diagnosed with type 1 diabetes 10 years ago and takes insulin subcutaneously. His temperature is really high. He lies supine with his right knee flexed and externally rotated. He resists simultaneous extension of the leg and thigh, particularly at the hip. The pathological process occurring in him most likely involves which muscle, and the answer was psoas major. He has a psoas major abscess. I don't know how relevant it still is, but you can see your psoas major on both sides of the vertebra. I don't know how relevant this question still is, but I just wanted to make sure I put everything here, and then it's up to you if you want to decide you want to know this or not. Alright. So this image here is showing you your vertebral disc. You have your erector spinae muscle, which basically help you stand erect. Right. So you have the different names for these guys. Very much low yield stuff, except the latissimus dorsi. Right. But that's not even the latissimus. We already saw the latissimus. It was related to the shoulder. So that's about it. Let me make this bigger. Sorry. Right, so what is this? Longissimus. Okay. Multifidus and iliocostalis. You don't need to know these muscles. Just know they are the erector spinae muscles. You have your quadratus and your psoas major. And this was a psoas major abscess in this guy. Right, so really don't know how that would ever pop up. But if you need to pick it, if something weird is showing up on your step 1, just be ready for that. Here we see the medial compartment of the thigh. So anterior compartment was all femoral. Medial compartment of the thigh. We're looking at that right now. Right, so the medial compartment of the thigh, you just have one thing that's femoral nerve, but may receive a branch from obturator nerve, and that's your pectineus muscle. Other than that, everything else is generally obturator. Right? Everything else is obturator. And these guys are for adduction. Right? Adduction. Gracilis is, let me see, where's the action? Adduct, right? Rotates thigh laterally. Obturator externus. You could tell from the name if it's obturator externus, it rotates it laterally, externally. So here in this image here, you can see the obturator nerve. It has a supply of the lower medial thigh. The upper medial thigh was these guys. That's genitofemoral. Lower medial thigh is obturator nerve. And the anterior cutaneous branch of the femoral nerve takes care of the anterior thigh sensory innervation. Right? We didn't have the sensory innervation picture up here. So anterior thigh is this green section, which is femoral nerve. Right? And then you can see anterior thigh and the anterior leg, right? Anterior cutaneous branch is the femoral nerve, saphenous branch of femoral nerve. All of that is turning out to be your femoral nerve. Okay, femoral nerve. Oh, it's lateral leg. Okay, so that's that. Let me see now. Femoral nerve, artery, vein. We already talked about the navel stuff when we were in GI. This is the posterior compartment of the thigh. So now we're looking at flexors, right? And these guys, although they're posterior compartments of the thigh, Only the biceps femoris, which has the word biceps in it, is a flexor, right? Flexes leg at knee. The semimembranosus and semitendinosus, these guys extend the thigh at the hip, right? So it's kind of like flexing, but not really. If you're extending at the hip, you're bringing up your hip, like you're bringing your thigh upwards. That's what extending the thigh at the hip means. Whereas the biceps femoris actually flexes the leg at the knee. So if this is my leg, right, then this is the front part now. Remember, your legs are rotated the other way around. So extending at the hip means lifting this upper part up like that. Whereas flexing at the knee means going like this backwards, and like you'd be basically kicking your butt with your heel. That's what flexing at the knee means. So that's your biceps femoris guy. And these guys are all tibial. Right? Tibial, tibial, tibial. Okay? So that's all you really need to know for that portion right here. Posterior compartment of the leg, you have the soleus, which is pretty much the biggest muscle there. You usually feel that one when you flex your lower leg. These you can't feel. These are deeper. So tibialis posterior, flexor hallucis longus, flexor digitorum longus. These are the guys that are going to have tendons connecting to your toes. And all of these are tibial. Right? Really straightforward. All of these for your posterior compartment of the leg are tibial. Anterior compartment of the leg, deep fibular, right? And then they also go to your foot, and the entire anterior area was superficial fibular, anterior compartment of the leg, and the sole of the foot was deep fibular. Right, so that's your anterior compartment leg muscles. All of these guys and the anterior compartment of the leg are getting their muscular innervation from the deep fibular nerve, which is deep peroneal, same thing. The two things are interchangeable. Lateral compartment of the leg, all the way down here, where we saw the talofibular ligament and all that stuff. This is just going to be superficial fibular nerve, right? And that's the same guy that innervates your dorsal foot, but not the middle area between the toes. All your butt muscles, right? So this is pretty significant. You can see your gluteus minimus. They cut out the gluteus medius, and then the really big one here. This is your gluteus maximus, which is also cut. Right, so those are your three gluteus guys. In between, you have a bunch of little ones, but they're horizontal, right? Because that's going to help you move better. These guys in between, so your piriformis, your germilius, obturator internus, right? These are all your little muscles over here. Inferior germilius. You never get a question on them, but you should know that they're there. Right? Quadratus femoris, and then these two right here, the semitendinosus, biceps femoris. Really good to at least see these muscles once, right? Definitely see them at least once so you know where they are. But mainly speaking, you just need to know the gluteus guys, and that's your gluteal muscles right here, right? Superior gluteal nerve, inferior gluteal nerve, as we talked about them just now, and that's pretty much the end of that. Then they just go in to talk about the ankle, right? And you get to talk about a little bit of radiculopathy, and we'll keep going until we finish up with the anatomy. So I'll finish up the rest of this in the next video. But definitely spend some time, go back, look at the random parts of your lower leg nerves, lower extremity nerves, know how they travel throughout the muscles, and know what muscles they innervate, as well as what part of your thigh is innervated by what nerve, sensory innervation. You get questions about the sensory innervation, you get questions about not being able to abduct or adduct based off of something a patient might have gone through, whether it be surgery, trauma, whatever it was, all right? So make sure you spend some good time knowing that. Get that all done today so you don't have to revisit it for a while. And think about it in your mind without the book in front of you. That's the main thing. Always think about things that you studied on a certain day without the book in front of you so you can really confirm how well you grasped it.